The standard ECG has a total of 12 leads, 6 limb leads, and 6 chest leads. 3 limb electrodes are used to create 3 bipolar leads, leads 1, 2, and 3, as well as 3 unipolar limb leads, AVL, AVR, and AVF. And together, the 6 limb leads provide information about the direction of current through the myocardium in the coronal plane. The chest, or precordial leads, are unipolar leads named V1 through V6, and are created by arranging 6 electrodes around the chest wall to provide information about the direction of current through the myocardium in the axial plane. Combining the limb and chest leads essentially takes you from a 2 to a 3-dimensional perspective, and if you can identify where certain abnormalities occur, you can not only identify, but also localize cardiac pathology. There are a number of ways that the 12-lead ECG is used to localize pathology, but perhaps the most important and instructive is for acute coronary syndrome. Different branches of the coronary arteries all supply different regions of the heart, and abnormal Q waves, ST segments, or T wave changes in the leads pointing to that region suggest focal ischemia in that territory of the heart, often caused by obstruction of the coronary artery that supplies it. The right coronary artery supplies the right ventricle, and its anterior wall is detected only by lead V1. But its acute marginal branch supplies the inferior wall of the heart. An inferior wall ischemia is detected by leads 2, 3, and AVF. The LAD branch of the left main coronary artery supplies the intraventricular septum, detected by V1 and V2, as well as the anterior wall of the left ventricle, detected by V3 and V4. The circumflex branch of the left main coronary artery supplies the lateral wall of the left ventricle, detected in the axial plane by leads V5 and V6, and in the coronal plane by leads 1 and AVL. And that's not all. When it comes to ST elevation myocardial infarctions, it's important to look not only at the leads facing the affected wall, but also the leads facing away for reciprocal ST depressions. Lead AVL and often lead 1 are the reciprocal leads to the inferior wall, and leads 3, AVF, and often 2 are reciprocal to the lateral wall. But the most important reciprocal changes are those found during occlusion of the posterior descending artery that supplies the posterior wall of the heart, because there are no leads that actually face that wall. But reciprocal ST changes in the anteroseptal leads, especially V2 and V3, can alert you to the presence of a posterior STEMI. The different leads of an ECG are like multiple views in an X-ray. They provide different perspectives of the same thing that help you understand the heart in 3 dimensions. And if you can conceptualize how each lead is arranged in space, you'll be able to understand why certain pathology manifests on certain leads, rather than having to memorize diagnostic criteria.